Hello and welcome to WHO and today's virtual press conference on global health issues. It's Friday, 5 September, and we are here at WHO HQ in Geneva. My name is Christian Lindmeier, and I'll take you through today's press briefing. Now, let me introduce the participants. First and foremost, in the middle, we have Dr. Tedros Adhanom Ghebreyesus. To his left side, to your left side, so to his right side, we have Dr. Gweazu. He's Executive Director, Health and Emergencies Program. Then we have Dr. Kate O'Brien, Director for Immunization, Vaccines and Biologicals. Then we have Deus Mumangizi. He's Director of Policy and Standards for Medicines and Health Products. Next to him is Lorenzo Moja, a scientist here at the Secretariat of the Expert Committee on Selection and Use of Essential Medicines. Then to the left of Dr. Tedros, we have Dr. Maria van Kerkhove, Interim Director of WHO's Department of Epidemic and Pandemic Management. Next to her is Dr. Abdirahman Mahmoud, Director for Health Emergency Alert and Response Operations. Then we have Nabil Tabal, he's Middle East IMST Incident Manager. And last but not least, Dr. Janet Diaz, Unit Head for Safe and Scalable Care. Welcome all of you. We have also Dr. Rick Peppercorn online for the questions, our representative for the occupied Palestine territory. He's available only in the first half hour, so we'll get to that. But if we have questions in the beginning, would be good to take those first. Otherwise, we'll have other colleagues for that here in the room as well. We'll have a special guest as well, as we had the Mpox Emergency Committee yesterday, but I'll leave that to Dr. Tedros to introduce. Over to you, Dr. Tedros.
Thank you, Christian. Good morning, good afternoon, and good evening. More than a year ago, I declared a public health emergency of international concern over the spread of Mpox in Africa on the advice of an emergency committee convened under the international health regulations. Since then, the emergency committee has met every 3 months to evaluate the outbreak. Yesterday, they met again and advised me that, in its view, the situation no longer represents an international health emergency. I have accepted that advice. This decision is based on sustained declines in cases and deaths in the Democratic Republic of the Congo and in other affected countries, including Burundi, Sierra Leone, and Uganda. We also have a better understanding of the drivers of transmission, the risk factors for severity, and the most affected countries have developed a sustained response capacity. Of course, lifting the emergency declaration does not mean the threat is over, nor that our response will stop. And we note the Africa CDC's decision yesterday that Mpox remains a continental emergency. The possibility of continued flare-ups and new outbreaks remains, requiring adequate surveillance and response capacity. Ongoing efforts are needed to protect the most vulnerable groups, particularly young children and people living with HIV. WHO, Africa CDC, and other partners have maintained a coordinated emergency response, supporting countries to reduce transmission, address stigma, and expand access to testing, care, and vaccination. Nearly 6 million vaccines have been pledged. More than 3 million doses have been delivered to 12 countries, and just under 1 million doses have been administered. So we have made much progress, but we still face significant challenges. Mpox clades continue to circulate. Surveillance and access to diagnostics remains patchy. Response capacities are under strain from limited funding, and community engagement requires sustained investment and local partner coordination. WHO and our partners are working to mitigate these risks and sustain support to countries. However, Financial resources are still very much needed to support this work. Standing recommendations for mpox have been extended for another year until August 2026 to support member states worldwide. I have also extended emergency use listing for mpox vaccines and diagnostics. To say more, I'm honored to welcome the chair of the Emergency Committee, Professor Dimi Ogoina from the Niger Delta University in Nigeria. Professor Ogoina, you have the floor. Can you please unmute your audio? We can't hear you.
Okay, can you hear me now?
Yes, thank you.
Okay. Thank you very much, the DG and other members of the WHO Secretariat, partners, the media, and other guests. Good day to everybody. I think it's appropriate to first appreciate the DG and the WHO for the leadership and commitment to addressing global health challenges, including the mpox outbreak, which was declared a public health emergency of international concern in August 2024. On behalf of the committee, I think it's also important to appreciate the DG and the WHO for the opportunity given to all of us to contribute to addressing the problem of mpox. The emergency committee had its 5th meeting yesterday, Thursday, the 4th of September, 2025. 11 of 16 members and 2 advisors were in attendance. Members listened to presentation from the WHO Secretariat from most affected state parties and other countries outside Africa. They presented, gave an outline on the trajectory of the mpox outbreak over time from the August 2024 to date, and the trends in cases, in mortality, and the response capacity. The key findings from that presentation include some positive trends which have been echoed by the DG. There has been a sustained decline in the number of cases of mpox in the African continent overall, and also in the most affected countries of Uganda, DRC, Sierra Leone, and Burundi. There's also been a remarkable decline in the case fatality rate that has been observed in the DRC in endemic regions from 3.6% to about 1% over the period of 1 year. We have also noticed some remarkable increase in the testing capacity, especially in the overall, it has increased from about 30% to over 60%. In the DRC, it's still 54%, which is, of course, we know is very, very suboptimal. In many of the countries have improved their ability to diagnose and case finding, search for mpox. And also there has been local investment from the ministries and government in the mpox response. However, there are some concerns that were observed from the presentation and members. The first was related to the high case of fatality amongst people living with HIV/AIDS, especially in Uganda and Sierra Leone. Also observed was the tendency towards higher morbidity and mortality amongst infants and young children in parts of DRC, especially in endemic regions in the DRC. Of course, it's encouraging that Clade 1B that was thought to be a challenge has been exported to many countries, but has not resulted to sustained community transmission, and also not resulted to significant case fatality, with the case fatality less than 1%. Of concern to the members of the committee is the need to sustain the benefits and the gains of the declaration of the public health emergency, which has resulted to increase the political commitment, increase mobilization of resources, and also increase in response strategy to the mpox outbreak. Having looked at the presentation from the WHO Secretariat, the presentation from the state parties, and the data available, and the criteria used for determining the public health emergency of international concern, the committee resolved to advise the DG of the WHO to terminate the public health emergency of international concern and to transit to a more coordinated, proactive, short and long-term strategy to address the challenge of mpox globally and in Africa. The committee observed that mpox remains a public health concern globally and especially in Africa, and there is need for us not to be complacent about the response strategy and not throw away what we have gained from the declaration of the public health emergency. The committee recommended the termination of public health emergency because it no longer fulfilled the criteria for declaration of public health emergency as indicated in international health regulations in 2005. But mpox remains a public health concern, especially in Africa, and that there is need for a proactive, urgent support for the African continent. There is need for solidarity and partnership to ensure we address the gray areas, we improve response, improve diagnosis, surveillance, availability of vaccines, because currently vaccines being available to the African continent is still limited, and deployment of vaccines is hindered by logistic and financial challenges. The committee ultimately resolved that there's need for global solidarity in the response to mpox, and there's need for continued investment, and also to improve on the successes that have been achieved from the declaration of the public health emergency. And the committee also noted that failure of the globe and stakeholders to continue to invest in the mpox response will put the world at the risk of a resurgence of an mpox outbreak, and there's need for vigilance and continuous support. Thank you very much.
Thank you so much, Professor Ogoina, for your leadership of the Emergency Committee over the past year and for your ongoing commitment to the fight against mpox in Africa. Thank you so much. Of course, mpox is only one of many health threats in the Democratic Republic of the Congo. Yesterday, the government of the DRC declared an outbreak of Ebola virus disease in the central province of Kasai. So far, 28 suspected cases and 16 deaths have been reported, including 4 health workers. WHO already has staff on the ground in Kasai, with more on the way. We're joining rapid response teams to trace contacts and find cases. We're collecting and testing samples, and we're providing technical expertise in surveillance, infection prevention and control, treatment, risk communication, and more. WHO has also delivered personal protective equipment, laboratory equipment, medical supplies, and a mobile lab. We had previously pre-positioned 2,000 doses of Ebola vaccine in Kinshasa, which we're releasing to vaccinate contacts and health workers. This is the 16th outbreak of Ebola in the DRC, and the government has rich experience from those previous outbreaks. I thank the government for its leadership in responding to this outbreak and for its transparency in rapidly declaring the outbreak and sharing the viral sequence. To fund the response, WHO has released $500,000 from our contingency fund for emergencies, and we appeal to donors to support the response. Now to Gaza. Over the past week, parts of Gaza have come under heavy bombardment as part of Israel's military incursion. If this continues, it could lead to an even worse humanitarian disaster, endangering water and sanitation facilities for nearly 1 million people, many of whom are already facing extreme food deprivation. As you know, famine was declared in parts of Gaza 2 weeks ago. Since the conflict began in October 2023, at least 370 people have died from malnutrition in Gaza, including more than 300 just in the past 2 months. And where hunger goes, disease follows. Lack of food and clean water and cramped living conditions are leaving people with weakened immune systems exposed to more disease. In the past months, more than 100 cases of Guillain-Barré syndrome have been reported, with 11 deaths, a syndrome that can occur after other infection and lead to paralysis. WHO is doing the best we can to alleviate suffering and evacuate those who need urgent medical care outside Gaza. Since October 2023, WHO has supported the evacuation of over 7,640 patients, including 5,300 children and 2,660 companions. But there are still more than 15,000 patients in Gaza who need urgent specialized care, including 3,800 children. More than 700 people have died while waiting for medical evacuation, including almost 140 children. However, the urgent problem we face is that too few countries are willing to receive them. We call for countries to open their arms to these critically ill patients. And we call on Israel to allow people to be treated in the West Bank and East Jerusalem, where hospitals closer to home can take many patients. Above all, we call on the government of Israel to end this inhumane war. If it will not, I call on its allies to use their influence to stop it. The most intolerable part of this man-made disaster is that it could be stopped right now. People are starving to death while the food that could save them sits on tracks a short distance away. And for what? The starvation of the people of Gaza will not make Israel safer, nor will it facilitate the release of the hostages. This is a catastrophe that Israel could have prevented and could stop at any time. Starvation of civilians as a method of war is a war crime that can never be tolerated. Doing so in one conflict risks legitimizing its use in future conflicts. While the wars in Gaza and Ukraine continue to make headlines, the war in Sudan continues to be the war the world forgot. Like Gaza, Sudan is also facing a hunger crisis with famine conditions confirmed in parts of the country. This year alone, over 770,000 children are expected to suffer from severe acute malnutrition. WHO is supporting 142 centers that have treated more than 20,000 severely malnourished children so far this year. At the same time, the country is facing a severe cholera outbreak, which has spread to all 18 states with more than 105,000 cases and 2,600 deaths. In August, WHO supported vaccination campaigns that reached 3.5 million people. And we will soon launch another campaign targeting almost 2 million people in Darfur. Since November 2023, over 17 million people have been reached with oral cholera vaccines. The situation is especially severe in the region of North Darfur, where the city of El Fasher has been under siege for more than 500 days. More than 260,000 people need urgent health assistance. 35 health facilities have been destroyed. There are 5,000 suspected cholera cases and 98 deaths. 130,000 children are suffering from malnutrition. And survivors of sexual and gender-based violence need urgent care, including mental health support. UN humanitarian aid, including WHO supplies, hasn't reached the city in over a year. We call for the immediate opening of safe and unimpeded humanitarian access to El Fasher to meet the mounting health needs and save lives. We call on the RSF to lift the siege, and we call on all parties to the conflict to end the war. Finally, today, WHO is releasing the latest editions of the WHO model lists of essential medicines and essential medicines for children. These lists are among WHO's most important products, used in over 150 countries to shape public sector procurement, the supply of medicines, health insurance, and reimbursement schemes. The updated lists include new treatments for various types of cancer and for diabetes with associated conditions such as obesity. Medicines for cystic fibrosis, psoriasis, hemophilia, and blood-related disorders are among the other conditions. And finally, today is the last press conference for WHO's Director of Communications, our friend and colleague, Ghebreyesus, who is retiring after more than 6 years at WHO. Gabi has led WHO's communications through an incredible period in the organization's history, including the COVID-19 pandemic. She has done so with incredible dedication, energy, insight, empathy, and experience. Gabi, thank you so much for everything you have done and for who you are. Thank you for your outstanding commitment and contribution to WHO, and more importantly, to the people we serve. We will miss you, and we wish you every success for the next chapter of your life and career. Christian, back to you.
Well, thank you very much, Dr. Tedros. Thank you, Professor Boyner, and thank you, Gabi. Yeah, with this, we open the floor for questions. Please, again, raise your hand with the raise your hand icon and unmute yourself when it's your time to speak. I'll try to see if we can get one question through to Rick Pippercorn. I was told he might have to leave, but let me see if he's still online. So we have one question from the colleagues of BBC. Doctors in Gaza are talking about the spread of an undiagnosed virus. What do we know about it? What are the symptoms? How dangerous is it? Over to you, Rick.
Yes. Yeah, just coming back in, from Gaza last Monday, I was there again for more than 2 weeks. There's definitely an increase in acute respiratory infections, but we, I think, are constantly reporting on the various diseases. We've seen currently an increase in acute respiratory infections, and slight decrease, for example, in diarrheal diseases and in jaundice. This has not been linked. There was a lot of discussions about COVID. There was a lot of other discussions, etc. That has not been confirmed at all. I just want to make that very much as the first point. What we, of course, see currently in Gaza, in this environment, and it was described also by the DG, in an environment of malnutrition, and in some places even worse, with horrific conditions when you talk about water and sanitation and shelter. I constantly see this waste. People are much more prone to definitely all the waterborne diseases, but also respiratory infections. Also, people are incredibly crowded. You look at Gaza now, more than 86%, is incredible. The small Gaza, more than 86% is now what we call a militarized zone. So these 2.1 people, they are actually clustered in Gaza City in the north, and then mainly in the center and the west part, because as we heard also DGG, this military incursion is already hitting very hard on the east side of Gaza City. And then the central area, Deir al-Balah and Mawasi. So currently nothing confirmed. COVID definitely not confirmed. We definitely also struggle, and that's including in what was mentioned as Guillain-Barré syndrome. We struggle, and the health service struggle with the lack of proper laboratories, especially lab supplies and everything related to that. So if we get more details, we will inform you on this. Over to you.
Thank you so much, Rick. Next question goes to Nina Larsen from AFP. Nina, please go ahead and unmute.
Thank you very much for taking my question. I wanted to ask about the situation in the US and how concerned you guys are about the situation at the CDC. There was a letter from all of the CDC directors going back to the Carter administration warning about the health risks that the current Secretary of Health is putting Americans at, especially when it comes to vaccine access. There's also the Florida decision to remove the vaccine mandate there. So I was just hoping that you could say a little bit about what you think about what's been happening at the CDC. Thank you very much.
Thank you, Nina. We'll go to Dr. Kate O'Brien, Director, Immunization, Vaccines and Biologicals.
Thanks so much for the question. I think the most important thing that we should make sure that we're focusing on is, first of all, the CDC in the US is an incredibly strong institution with many excellent, outstanding, world-class scientists, and WHO has had a long-standing collaboration, and the world has benefited from the expertise that sits within the CDC. And I'm sure that expertise will continue. I think where we also want to address your question is on the question of vaccine mandates, and this is a topic that comes up not infrequently. I think it's important to remember that there are many aspects of our public health life where governments and institutions do have policies that help the public stay safe. Seatbelts, using corrective lenses for those who are driving vehicles, and the issue of assuring that vaccines are provided to all people who need vaccines is an important one. And there are many different policies that are used to enable and assure that vaccines are accessible. What is most important is that vaccines start and stop with trust. And without trust, there really isn't a vaccine program. And the second most important thing is the strong evidence base on which decisions about vaccines and the safety of vaccines and their impact are made. And the third is that vaccines are fully and in an unfettered way available and accessible to all people who need them. And so many countries have used policies that are called vaccine mandates that sometimes are misinterpreted as being sort of compulsory vaccines, and very few such countries have something called a compulsory vaccine. But vaccine mandates are very common in the data that is shared with WHO on an annual basis. In this past year, about 104 countries do say that they do have policies or laws that relate to requiring, encouraging children to attend school or childcare. So this is something that's very common. And we do recommend a context-specific approach to mandates. It's not the preferred way to assure vaccination because, of course, individual choice is the most fundamental part about what people are doing. But we have to be sure that the programs of immunization are providing a way for vaccines to be easily and readily accessible. And as I mentioned before, the public having accurate information, evidence on which they are confident that the programs are well crafted and bounded on safety and impact is the absolute most fundamental part. Many of the diseases, we have to remember, are deadly diseases. That's why we vaccinate. And so particularly for schools, which are environments where transmission, the mixing of children and kids are in classrooms and on playgrounds, it's really important that those kids are safe from what are deadly diseases. And that's the reason, the whole underpinning of why vaccines are so important. So although there are many different ways that vaccine programs can be encouraged and parents have access to vaccines that is not constrained by time, place, insurance status, very common for there to be policies that are around vaccine mandates. And the evidence does show that these can be effective. They can be the means by which children who aren't vaccinated are identified when they're registering for school. And as long as vaccines are then made available to them, this can increase coverage as well. In other settings, they're not very helpful. And so I really just want to come back to the context of the trust issue and the community issue. So it's very, very context specific. Thank you.
Thank you very much, Dr. O'Brien. Dr. Van Kerkhoff, you want to add?
Yeah, thanks. I just wanted to comment on the first part of that question because I think it's such a critical one and the importance of US CDC as a technical agency, the importance of national centers for disease controls or public health agencies are really critical in every single country, but the world needs a strong US CDC. We have continued to work with CDC throughout from a technical partnership, sharing information about what is happening, working with many of their experts across many disease-specific areas. That technical exchange continues, but it is really important that national governments, all national governments, have strong evidence-based institutions. And I won't go into what Kate talked about with the vaccines, but of course wholeheartedly agree, but it covers the entire spectrum of prevention, control, readiness, and response. So I think, we just want to make sure we continue to support all scientists, public health professionals around the world to ensure that they have the best evidence to make the best decisions. That's what we do here, but also to call on that expertise. We're very grateful for our colleagues at US CDC and the hard work that they do, as with other national institutes and public health agencies around the world.
Thank you very much, both. Next question goes to Elaine Fletcher from Health Policy Watch. Elaine, please go ahead and unmute.
Hi, thank you for taking my question. This is about the new EML. I have two questions, actually. One is about the insulin. You mentioned insulin analog as being something new in the table of medications. However, there were insulin analogs also approved, as I recall, in 2021 and 2023. So I just wondered if you could be a little more clear about if there's a new type of insulin analog that's been approved this time, and if so, what? And then in terms of also cancer drugs, I noticed that you have some new drugs for colorectal, cervical, and lung cancer, but I don't see any new breast cancer drugs there in the list. And I know that's been an issue in the past as well, sometimes because of the costs associated with those drugs. So just if you could comment on those two aspects of the listing. Thank you.
Thank you very much. Elaine, between Dios and Lorenzo, who wants to start?
Okay, I will start. Thank you very much for the question. In terms of insulin, indeed, you're right. We have had various types of insulin on the essential medicines list. We have had long-acting insulins and also medium-acting insulins, both human and recently analogs. What has been added to that to complete the whole range of treatment is the short-acting insulins. And this is also to make sure that all the ranges of conditions and that we have the treatment package to cover all the conditions that, that we need. And often these are complementary, and those where would conditions is appropriate to use long-acting insulin, but also